Today, for our video history, we are fortunate to have with us Dr. Robert Sokol. Dr. Sokol has been an active member of ACOG for many years, has done much for us, and we're extremely pleased that he'll be with us today to explain us a little bit about his life and our specialty of obstetrics and gynecology. Welcome, Bob. Thank you very much for being here.
Thank you.
To begin, let's begin with you. Start at the very beginning. Where were you born?
Rochester, New York.
You're a New York person.
Well, in Manhattan they think Rochester's in the Midwest, but yeah, I'm from New York.
I realize that the Hudson River is the definition between East and West. That's right. Where did you go to school?
Well, I was born in Rochester and stayed in Rochester, and actually went to college at the University of Rochester, and then did 3 years of college, and thought, gee, maybe I ought to go to medical school. Somebody said, well, you ought to apply. I did, so I got in, so I went, but I actually liked undergraduate and did finish my undergraduate degree. They gave me credit for the first year of medical school, and I finished my major in philosophy.
Your major was philosophy?
Yeah.
It was unusual at that time for a person going to medical school.
Yeah, but I really like the arts and liberal arts, so all three of my kids majored in liberal arts as well, and they're all physicians.
Where did you go to medical school?
I went to medical school at Rochester as well, and when I graduated, my wife and I decided, well, it was probably time to get out of town, so we ended up going to St. Louis to WashU. And the chair there was Willard Allen, and he was from Rochester. He'd been in Rochester, and I was actually very impressed with him. He was terrific. So went to WashU for my residency.
And after you completed your residency?
It was during Vietnam. So if I had not volunteered, I figured I'd probably get drafted. So I did volunteer, and it had the tremendous advantage of allowing me to finish I got lucky, I got selected for the Berry plan, and I was therefore able to finish my residency. And when I got done with my residency, I had a choice. I had an opportunity to go into public health service, but the problem is I interviewed at NIH, and I had a chance to go there or Washington, but they wanted me to do endocrinology. And there is nothing I found more boring than endocrinology. So I decided to go in the Air Force, and it was a terrific choice. Very, very useful. I ended up in South Dakota. I had no idea where South Dakota was, at Ellsworth Air Force Base. And my entire medical career to that point, I'd been in large academic health systems. There was always somebody to ask. Well, when I got to Ellsworth, there was one other obstetrician gynecologist who was a lifer, a very good guy, ended up on the faculty in South Dakota. But he left after a year, and then there was nobody to ask. If I couldn't do it, or didn't know how to do it, I was the only obstetrician in government service in areas of 5 states. So, a big character and confidence builder, because I think I delivered 750 babies in 2 years, and was supervised. I had general medical officers, probably at least that number as well, and did the requisite GYN surgery as well. And it really gave me a pretty good feel for actually practicing our specialty. And I thought, gee, that was in fact, it was very useful and fun and gratifying, and I very much enjoyed the Air Force. I also consulted down at Pine Ridge, the Oglala reservation, and it was an eye-opener. I'd spent most of my career in downtown. I've spent my whole career in downtown hospitals in the core city. Other than that, and it was just a rural slum. The conditions were terrible. The conditions for OB were terrible. They had no obstetricians. If they were high risk, we used to bring them up to Rapid City at 34, 36 weeks, and then they'd stay there until they delivered because there were just no resources. So it was interesting. So I did that for 2 years.
Let me take you back a little bit. You said you were in philosophy. What really tempted you to go into medical school then, especially after only 3 years?
Well, I had a discussion with my father. And my father had been brought up he went to college during the Depression. And I told him, well, I thought I wanted to I always knew I was going to be a teacher, professor. I knew I was going to be a teacher in 3rd grade. And I figured, I was good at one thing, going to school. So I kept doing it, and I'm still doing it. But I had a discussion with him, and he said, what are you going to do if you go into philosophy? You make more philosophers? Why don't you do something where you could actually make a difference? You could actually help people? Best advice I ever got. Really the best advice. And that's how I ended up going to medical school.
Did you apply to any place other than Rochester?
Oh yeah, I applied to several schools, but I got in all of them. I got into Yale and Einstein, Syracuse. I had a full tuition scholarship. A couple of reasons I decided to go to Rochester. The most important one of which is Roberta was in college in Rochester, and we started going together when she was a freshman, I was a sophomore, and I fully intended to marry her, so I stayed in Rochester.
And she is your wife?
Oh yeah, absolutely, the love of my life. People seldom see me without her.
I can attest to that.
Yeah.
Having seen you in many different situations over the years.
So I stayed in Rochester, and the second reason was I had a terrific interview with a guy who was the chair of pathology at the time, a guy named J. Lowell Orbison. And I got my first taste of really doing some science. I did, the usual high school science projects and stuff. But I got to work in his lab. I really liked him, so I wrote him a note before I was actually admitted, and said, gee, I'm not doing anything this next summer. What's the chance I could work in your lab? And he put together some dollars, public health dollars, and I did a summer in his lab and got a paper and won an award, saw my name in print, and that was it. I knew what I was going to do. And it wasn't laboratory research, it was clinical research. I've always tried to do things which are clinically relevant and hopefully improve care.
Well, along this line, when did you decide you wanted to be an obstetrician gynecologist?
I never had seen an obstetrician who knew anything about the field since I'd been delivered. That's the last obstetrician I think I'd ever seen. And I got on, in the 3rd year, I got on to the OB rotation, and I assisted at my first delivery. And I thought, boy, is this neat. I loved it. And I was with an attending, private attending, and I took a look at the placenta, and there was a piece missing. And sure as hell, I was right. She had a retained cotyledon. I said, oh, I can do this. And that's it. Now, it is true, I thought about when I was applying, they had a mixed OB-Peds residency at Rochester, and I really thought about doing that. Had neonatology, some of my early papers were with neonatologists, still are, because my research is very atypical for OB. I do long-term neurobehavioral development. I have kids as old as 20 years old that we're still following from conception. And I was always interested And it didn't really change in philosophy. I was interested in the mind, and I got interested in the brain. And my goal was to prevent brain damage in the offspring. And so I ended up in OB, but maintained an interest in fetal brain and still do that.
Now, once you finished your residency, where did you go? Or did you stay in Rochester? Or?
No, well, I finished my residency. It's in WashU. I went into the service, and when I got out of the service, I had looked at only really two opportunities. One was to go back to St. Louis, and there had been a change. I was Willard Allen's last executive chief, and the next chair was an endocrinologist. So he wanted me to come back and do endocrinology. Well, I'd already figured I didn't like that much, but I had a chance to go back to Rochester and work with Mort Rosen, who was interested in the brain and fetal brain. And I'm probably the only obstetrician in the world who is alive who knew how to read EEG, because I worked with Mort for a long time, and he was doing fetal EEGs. And we were doing fetal development. And I started off with him interested in labor progress and in cerebral palsy, asphyxia. And we were one of the groups that did a lot of work very early in fetal monitoring. Not as much as Ed Hahn and Dick Paul, but we were working with a guy named Larry Chick, was my colleague for years. And I think we probably, nobody this late remembers anything that happened so many years ago, but we probably had the second most publications on intrapartum monitoring of any group. And in 1980, we published a paper in the Green Journal which showed there was no longer any relationship between fetal monitoring and outcome. The kids look good regardless. Well, of course, it's treatment paradox. The reason was not that fetal monitoring didn't do anything. The reason is when somebody saw something that looked bad, they intervened. The kids came out all right, and that was fine. I decided I need to do something else. It was sort of a solved problem. A lot of people aren't great enthusiasts for fetal monitoring, but they forget what it was like without it.
How long did you stay at Rochester?
1 year. I got back, and Mort got a position, got recruited by Fred Robbins, who was the dean at Case, and had been at Metro Health, which was now Metro Health, who was then Metro General Hospital. And Fred Robbins was a Nobelist second Nobelist I had an opportunity to get to know. The first was George Whipple, who was the founding dean of Rochester, and he used to come to the pathology conferences, so I had a lot of exposure to him. And then Fred Robbins worked as hard actually to recruit me as a junior assistant professor. He was just a terrific guy. He won the Nobel Prize for polio vaccine. The science that made polio vaccine possible. And off we went after 1 year to Cleveland. So I've been sort of circling the Great Lakes. Started in Rochester, a little sojourn in the middle part of the country, and then over to Cleveland, and then I left Cleveland after a decade, went to Detroit.
When did you first get involved with alcohol?
In Cleveland. Weird, wonderful story.
Tell me about that.
Yeah. Well, like I say, I was doing asphyxia. I'm interested in the fetal brain. I was working with a neonatologist there, and we were studying growth restriction. I actually wrote a book on growth restriction, and again, that's old and nobody remembers. And also did a lot of work on obesity and kids who were infants of diabetic mothers, stuff like that. And one day, I was the associate director of the Perinatal Clinical Research Center, which Ted Quilligan had founded. It was a GCRC, the only one in OB in the country, and I trained there and then stayed there and became director over a decade. And it was a spectacular experience to teach me something about how to do clinical research. So I was sitting there one day, and a guy named Shelley Miller came downstairs. Shelley was the chief of psychiatry and went on to become the chief of psychiatry at Northwestern. And he said, "Bob, do you ever see this paper?" It was about 1974 or 5, and he showed me a paper from Lancet that had come out in 1973, which said alcohol was really a problem in pregnancy. Gave you this fetal alcohol syndrome. I said, "No, I hadn't seen it." He says, "Well, you have a database." I said, "Yeah, that's what I do. I do database stuff." It happened, I was friends with Cal Hobel, and we were using the Popris forms, which he and Erwin Merkatz, I actually had a piece in helping to design it as well, and it had alcohol on it. We'd been collecting data for, I don't know, 3-4 years, and it had alcohol as a prenatal risk. Now, in order to get it coded, you had to walk into the clinic with a brown bag and fall over, drunk, because it was certainly not coded well. And he said, "Gee, you know, I've got a site visit coming up. Could you take a look and see what our experience is?" I said, "Well, when's the site visit?" "Next week." He said, "Okay." So I spent a weekend and did an analysis and looked at all of the pregnancies where we had alcohol coded. And sure as hell, the kids were growth restricted, small kids, a lot of pregnancy complications. And so I called him up on Monday. I said, "Shelley, you know, you really got something here. It's very interesting." So the site visit team showed up that week, and Shelley came back downstairs. I did a little presentation. He says, "Well, they'll give me the grant if you'll be on it." I said, "Well, that's sort of strange. I'm an assistant professor." He says, "Yeah, but you're an obstetrician. They aren't going to give a grant on pregnancy to a psychiatrist unless I have an obstetrician." So I went over and quick, while they were there, this is like 2 in the afternoon, went and talked to Mort, to my mentor, and said, "Mort, do you think I really ought to do this?" He says, "Well, are you interested?" I said, "Well, yeah, it is interesting." And I can tell you, nobody was paying any attention. I was doing computerized analysis of labor progress, Manny Friedman kind of stuff, and I wasn't getting any interest in what I was doing. So I said, "Okay, it's a brain. It's a potentially preventable cause of brain damage, which is what I'm interested in." So I said to Shelley, "Yeah, I'll do it." And sure as hell, we got the grant. And it was a quick turnaround. From the time I talked to that site visit, I was invited within, I think, less than a month to testify, because it was a hot subject, new subject, in front of a Senate subcommittee on alcohol and pregnancy and the risks. This was before the Surgeon General, even before the college, which got in very, very early, told women not to drink. And I said, "Oh, that's interesting." All of a sudden, people are interested in what I'm doing. So that's how alcohol started, and I've gone on and done other substances, lead, but particularly cocaine. Still studying alcohol and cocaine.
As I recall, and admittedly it goes back a few years, you were the only one advocating about that, at least publicly, not that the people weren't doing it privately around that time, and that you became the face of fetal alcohol syndrome.
I think that it certainly, there were some psychiatrists at Boston University, for instance, who were interested in alcohol and pregnancy and did some studies. And psychologists. There were very few people in OB. And the reason, I think, there's a lot of funny things that get said, but I think the reason is it wasn't like thalidomide. Thalidomide had some very specific abnormalities which were hard to mistake for anything else. With alcohol, the congenital anomalies are substantially increased, but they're all the same stuff, so it fell into the baseline. And there was enough drinking, so everybody said, well, gee whiz, I was exposed to alcohol. And the difference is there's differing susceptibilities, and the effects that people see are at the high end, which is still relatively rare. We're down to about 10% of women drink during pregnancy, about a third of those heavily enough to really do some substantial damage. Now, there were very few people interested. It took a long, long time.
So I guess we can truthfully say you were the pioneer. That's not a bad legacy, Bob.
No, I never sort of looked at myself as a pioneer, but I always figured pioneers, you have to have cowboy boots and a hat.
But you were west of the Hudson.
Yeah, that's true, west of the Hudson.
How long did you stay at Western Reserve there?
I was at Case at Metro Health for a decade, and I'd had a couple of offers to leave. And I thought about it, and I looked at a couple of associate chairs at Penn, Indiana, and Mort and I actually got along very, very well, and I knew it was going to cost me a lot of time. I knew what happened when we moved after a year. I think any time you move, it costs you a lot of time on your science, and I was publishing a lot of papers. I mean, my career has basically been, I see patients, I love to be in best docs, it's very nice, but my career has really been as a researcher and a research administrator. So I looked at moving, and I was in a terrific place. I had a lot of resources. I was in a clinical research center, and the only one. And I said, well, I don't think I'm in much of a rush to move. But I got an offer to look at a chair in Detroit at Hutzel and at Wayne State, and the dean there had been at Northwestern. I probably ended up on his list through Al Gerby, because he'd published, it was Henry Nadler, and his work was amniocentesis for genetic diagnosis, which he did with Al, and I knew Al through the college. And I know for sure that I wouldn't have gotten that job except for Al. He really pushed. And I beat out somebody else, which we won't go into, from the other last candidate was from Northwestern, in fact. And has since been a chair and all kinds of stuff. But so I ended up getting an offer at Wayne State, as I like to say, in magnificent downtown Detroit. And I've been there ever since. I was just a good fit.
How long did you stay as chair?
I stayed chair for 6 years. I believe that I am still the only person ever to serve as permanent chair at Wayne State who didn't get fired. And the reason I didn't get fired is I became dean. Then I got fired. And that's the way, this is Detroit, and in Detroit it's some places, you go to Iowa and you can serve a couple of lifetimes as the head of the department there. Willard Allen at Wash U served from 1939 to 1966. That's the history. At Wayne, nobody serves that long. It's sort of the corporate model. But it was a perfect fit for me. Very business oriented, in a rush to get things done. It was a terrific move. I've loved being at Wayne.
After you became dean, did you still continue any of your work in research?
Absolutely. I think if you want to be either chair or dean, you won't like the job unless you can get your jollies by having other people be successful. On the other hand, I had a university president who pointed out that really who you are as a professor, and I always said that's who I am, and it's very important to maintain your own productivity. I had this happen this week. Yesterday I finished slides. We're doing a retreat from the research center that I direct, and I asked the guy who's running it, I'm not running the retreat, if I should present science. He said, oh yeah, very important, because you have to lead by precept. She says, you got to do it yourself. If I was going to expect other people to do research and be good at it, I had to continue. And I was able to stay funded throughout the entire time I was chair and dean, and I'm still funded.
Did you consider leaving after the deanship, going some other university?
Well, I thought about it, and what everybody said I should do is when I stepped down, I served two terms plus a year of interim. And everybody said, well, you know, why don't you go, you could actually go and make a living, go be vice president for a drug company. The problem is it's not who I am. I'm a professor. I had a very nice provost who felt that she didn't want to give me a title of emeritus dean, not because I didn't do a terrific job. She thought told me that going away party, I was the best dean the entire university probably ever had. But she thought that I always had a strong academic bent, and she made me a distinguished professor, which is probably the nicest title I've had.
And you're currently the distinguished professor?
Yeah, and I also have a named chair and director of the Mott. I got a lot of titles, director of the Mott Center, and I'm the John Malone Jr. chair, endowed chair, and John had been a junior faculty member when I came, and then worked his way through, became chair, and stepped down and unfortunately died. His dad is also an obstetrician, is still alive, and I go sit in front of him grand rounds every week.
What is your major focus of research currently?
Well, I'm still trying to prevent brain damage. And what we've done is I moved into translational research, and it's called SBIRT, which is screening, brief intervention, and treatment. And we've spent a lot of time trying to get obstetricians to find out about whether or not women are drinking and to give them good advice. Very hard sell and very hard to get done effectively. And the grant we just submitted said, you know, maybe we've got the wrong token. Maybe we ought to work with the office nurses. So we're going to try, see if we can convince them to do it and get the doctor's blessing, but have somebody else actually ask the questions. And I've also got another grant, NIH grant, that I'm a co-investigator on, not the PI, where we're trying to use computers. So we're still trying to get what we've known in terms of getting women not to drink, because there's very good evidence that if the doctors will intervene and do something, women actually listen. And you can be successful about 70% of the time. It's in one of the committee opinions from the college. It's about as successful as treatment of hypertension or diabetes. The problem is getting people to do it. So we're still working on it.
Tell me how you like your current position in the college as the editor of our print.
I love it. And there's a number of reasons I like it, but the most important one is I have learned more about general obstetrics and gynecology again than I think I've ever known. I tend to introduce myself, you know, I'm subspecialist maternal fetal. However, I am undoubtedly the only perinatologist in the world with a practice limited to the menopause. I always practiced and still practice general gynecology and really like it. So if we get a subject that's interesting, I get to edit it and read it. I've met a load of people. It's great fun. It's been a tremendous honor to have that job. I really appreciate your having asked me to do it.
You've done an outstanding job. It's one of our most popular series, and I appreciate you've even allowed me to do a few of them.
Oh, yes. No, you were terrific. Absolutely terrific.
Bob, it's been a real pleasure to talk to you, learn about your career. I do think you're one of the icons in our specialty. You are the one who's pushed fetal alcohol syndrome to the point where I think every OBGYN in the country, and probably in the world, owes you a debt of gratitude, because this was not something that was well known. And I can't thank you enough for coming, spending the last half hour talking to us, telling about your marvelous career. Thank you for all that you have done.
Ralph, thank you.
Thank
It's
you.
been a real pleasure.